My name is Alessandro Vannucchi. I'm an hematologist and the director of the Center of Research and Innovation for Myeloproliferative Neoplasm at the University of Florence. Today, I'd like to deliver you some brief notes about the latest news regarding CPI-0610, that is a drug that is currently under clinical trial experimentation in patients with myelofibrosis. This small molecule is an inhibitor of a large family of proteins that are called BET proteins. These are proteins that work in the nucleus, in the nuclei of the cells, and have different targets at the level of genes that control the release of inflammatory cytokines that are known to be significantly increased in patients with myelofibrosis, as well as to control the erythroid and megakaryocyte differentiation. And therefore, CPI-061 is a drug that can downregulate the release of inflammatory cytokines, as well as promote the erythroid differentiation and the maturation of megakaryocytes. There are currently two studies, or better, two parts of one studies with CPI that is called the MANIFEST trial. The first arm, arm 1, is as a monotherapy in patients who are resistant, refractory, or intolerant to ruxolitinib. And this arm 1 includes two cohorts of patients, one of patients who are transfusion dependent, and the second one for patients who are not transfusion dependent. In the MANIFEST arm 2, on the other hand, the drug is added on to ruxolitinib in patients with myelofibrosis who have suboptimal response to ruxolitinib. And again, there are two different arms, one including patients who are transfusion dependent, and the other one for patients who are not transfusion dependent. So at the last ASH, the preliminary results of the study have been presented, and I can anticipate that they are really of interest. As regards the arm 1 of patients who are transfusion dependent, there were 21% of the patients who converted from being transfusion dependent to transfusion independent. And also in the group of patients who were not transfusion dependent, half of these had some increase, at least 1.5 gram per deciliter increase of hemoglobin, suggesting in both cases that the drug is indeed active in terms of increasing hemoglobin levels, both in transfusion-dependent and non-transfusion-dependent patients. For patients who are not transfusion-dependent, the proportion of those who obtain a reduction of the spleen volume of at least 35% as compared to the baseline levels was 30%, and almost 50%, actually 48% of these patients also had a significant improvement in symptoms. On the other hand, in the cohort of patients who were transfusion dependent, the effects on the spleen and on symptoms were less impressive. Actually, 8% of the patients had both or either an increase in the spleen and or in improvement of the symptoms. For patients who were on Ruxo, and in these patients, CPI was added on to Ruxo because of insatisfactory response, the proportion of those who transformed from being transfusion dependent to transfusion independent was 36%. And there was a clearly progressive reduction in the transfusion intensity dependency in these patients over time after the addition of CPI to ruxolitinib. And in terms of spleen volume reduction, this was around 30% in patients who were non-transfusion dependent, and about 40% there was also an improvement of symptoms in these patients. The proportions were not so much different in patients who were transfusion dependent, and there were around 20% for spleen volume reduction and about half, 46%, for improvement of symptoms. The drug was overall well tolerated. There were few side effects. These were mainly gastrointestinal side effects, And the most common hematological toxicity were thrombocytopenia and anemia for those patients, of course, where the drug was not active in improving anemia. So overall, these data are of particular interest because they target both patients who are on Ruxo or when the drug is used as monotherapy. And I think this is really a novel paradigm of drugs because we know that drugs that are JAK inhibitors and target a protein, JAK2 or JAK1, that are cytoplasmic proteins. Here we have a drug that is active mainly at the level of the nucleus and is regulating gene expression. So we are waiting for the extension of this data and hopefully the start of phase 3 trials to fully confirm the impact of CPI for the management of patients with myelofibrosis.